Okay, good afternoon, everyone. My name is Alberta Noonan. I'm from the New England Quincy, Ohio, and I will be your monitor for today's webinar, Get Primed for Data Submission via the CMS portal. The Quality Innovative Network Quality Improvement Organization works with healthcare providers, stakeholders, and communities across New England on data-driven quality initiatives to improve patient safety, engage patients and families, and improve clinical care at the community level. Thank you for joining us for today's webinar. Before we get started, just a few housekeeping items. This call will be recorded for training purposes. I'll provide you with details on accessing the recording at the end of this webinar. The phone lines will be on mute for the duration of the presentation. We will take questions at the end. I will provide you instructions on how you can ask a question over the phone or pose a question in the chat box. Please make sure to send all questions to all attendees. At this time, I'd like to introduce Karen D'Antonio and Susan Whitaker. Karen D'Antonio has more than 20 years of experience in nursing healthcare management experience that crosses multiple healthcare settings, principally in home health and primary care. As Health-Centric Advisor, Karen supports the physician practices through the Quality Payment Program and Comprehensive Primary Care Plus initiative. Susan Whitaker is a certified professional coder and certified professional medical auditor with more than 20 years of experience in medical services delivery within the physician practice setting. Susan now works with Health-Centric Advisors supporting physician practices through the MIPS Quality Payment Program. This information in this presentation was prepared as a service to the public and is not intended to grant rights or impose obligations. This information may contain references or links to statutes, regulations, or other policy materials. The information provided is only intended to be a general summary. It is not intended to take the place of either the written law or regulations. We encourage readers to review the specific statutes, regulations, and other interpretive materials for a full and accurate statement of their contents. At this time, I'm going to turn this over to Karen D'Antonio.
Thank you, Alberta, and good morning, everyone. Susan and I thank you for taking time out of your busy day to join us for this session on claims-based MIPS quality measure reporting. We realize many of you are finalizing your MIPS submissions for 2017, and the process has been challenging. Today we will focus on claims-based reporting, and our goal is you will learn a few tips and resources for successful reporting in 2018. Our agenda today includes claims-based reporting, what is claims-based MIPS quality measure reporting, and when this may be the best option, and also operationalizing claims-based reporting, code identification and setup, and creating workflows and training the staff. These are the MIPS performance categories and scoring for 2018. The claims-based reporting that we will discuss today pertains to the quality category, which is now 50% of the total MIPS score. Data completeness for the quality category was raised to 60% for 2018. This means that at least 60% of the provided applicable attributed patients would need to have quality measures reported for them. Improvement activities remain at 15% of the MIPS score, and advancing care information remains at 25% of the score. The cost category is now 10% of the final MIPS score. CMS will figure this for you based on total expenditures for care given. So what is claims-based reporting? Claims-based reporting is submitting quality data to Medicare Part B on individual patient basis with HCPCS or Category 2 CPT codes on CMS 1500 claims forms. Quality codes are submitted on claims with visit and/or procedure codes and sometimes with specified ICD-10 diagnoses codes. Just remember, only Medicare Part B patients are included when reporting via claims. Medicare Advantage Plan patients are not included in this MIPS reporting method. So the next question is, when do you consider claims-based reporting for 2018? First, you need to determine if you are an eligible clinician. So the questions you would ask are, do you exceed the low volume threshold? More than $90,000 in Part B revenue in 2017, or more than 200 Medicare Part B patients. If you exceed these thresholds, then yes, you are eligible for MIPS reporting in 2018. For the low volume threshold, CMS takes the Part B revenue, those allowable charges, from the 9/1/2016 to 8/31/2017 window. So if you want to run an internal revenue report to see if you are exempt for 2018, you would run that time frame. There is also the QPP, on the QPP CMS Medicare website, the participation lookup tool will be available, so you can tell your eligibility status on that as well. The next question to ask is, do you have a certified electronic health record? If you answer no, you do not have an electronic health record that can submit data for you or produce a file for you to upload to the QPP portal, then claims-based reporting may be your best option. So you know now you're an eligible clinician. The question would be, how much data to submit? So what you want to submit you need to report at least 6 quality measures for the entire year and attest to improvement activities for a 90-day period. Those without a certified electronic health record will have a 0 score for advancing care information category. Those with a hardship may apply for an exception to have the ACI score re-weighted to the quality category. A hardship may include lack of internet access, lack of control over the electronic health record, or providers affected by disaster. You would need to check on the QPP.cms.gov website for more information and for the hardship applications. I went over one too many, sorry about that. So I want to talk a little bit about the minimum MIPS score needed to avoid the negative 5% payment adjustment in 2020 is 15 points. So there are a few ways to meet the 15-point minimum based on your practice size. Again, this is just to avoid the negative 5% payment adjustment. For small practices, and those identify as 1 to 15 clinicians, you would report 6 quality measures or perform and attest to improvement activities, 1 high weight or 2 medium weight. If you're a large practice, more than 15 clinicians, you would report 6 quality measures that meet 60% data completeness or perform and attest improvement activities, 2 high weight, 4 medium weight, or a combination to equal 40 points. The recommendation is to report as much data as possible to cover for any measures that may not be met and to earn as high a score as possible and perhaps gain that positive adjustment. So it's really important to really look at all the measures and submit as much data as you have available to you. I'm going to pass the presentation over to Susan now, who will get in a little more detail on what these quality measures are and the categories that you would need to submit for. So Susan, in 1 second, I'll be able to pass to you. Thank you.
Great. Hello, everyone. Thank you, Karen. In this portion of the webinar, we'll talk about operationalizing claims-based reporting in your practices. So the first step is to choose your quality measures. You would choose measures from the MIPS 2018 measures list, which is found in the CMS resource library at the link below. And you would download the quality measures specification supporting documents and then open the claims registry file. Within that file, there are several resources, one of which is the 2018 measures list. From the measures list, you would choose at least 6 measures, including one outcome measure, or if an outcome measure is not available, report another high priority measure. If less than 6 measures apply to your specialty, then report on each applicable measure. The measures you reported on in 2017 may still be available. However, be aware that there have been some changes to the measure specifications. So this is a partial screenshot of the 2018 measures list. This is an Excel worksheet, so the list can be sorted by specialty and by submission method, and you can easily see what measures are applicable for claims reporting in your specialty. This spreadsheet will also indicate whether the measure is an outcome measure or a high priority measure, and whether or not it is topped out. We'll talk more about what topped out means in a few moments. So while you're in this measures spreadsheet, make a note of the quality measure number for the measures you choose, because you'll need it to find your specification sheets for your measures. And just as a point of information, there's about 73 claims-based measures to choose from. So most quality measures have scoring benchmarks, and these are located also in the CMS Resources Library, and they're specific to each submission type, claims registry or EHR. So reference the benchmark table to see what score you could possibly earn for high performance in each measure. And you may want to bypass some measures that are topped out. A topped out measure is one that is not showing much variability. It's typically high scoring by all providers, and therefore lower scores are awarded for high performance. The first benchmark example here is for the claims measure number 12, primary open-angle glaucoma optic nerve evaluation. The average performance on this measure, you can see, is 96.5%, and it is topped out. So a high performance of less than 100% would only yield 3 to 3.9 points for this measure under decile 3. Whereas the second example, which is measure number 204, use of aspirin in vascular disease, is not topped out. And high performance for this measure will yield a higher score. And also please note that some measures have no benchmarks, and as long as data completeness is met for them, 3 points will be awarded. So what if there aren't 6 measures to report? Some clinicians may not find 6 quality measures to report in their specialty, and it is okay to report applicable measures from other specialty sets. However, when none are available and less than 6 measures are reported, CMS will automatically apply what is called the Eligibility Measure Applicability Process, EMA process, to determine if additional clinically related measures could have been submitted. So this is similar to the MAV process that was used for PQRS. The 2018 measure applicability data sets are not released yet. However, you might take a look at the EMA 2017 data in the CMS Resource Library to get an idea of how this works, and then keep an eye out for more information on the 2018 EMA process. There are a couple of supporting documents that it's really important to read before you begin reporting your measures. And this first one is the 2018 Measure Specification Flow Guide for Claims Submission. Here you'll find the definitions of the numerator, denominator, measure periods, inverse measures, and information on quality claims processing. And you'll find this in the resource library. It's actually titled Individual Measure Guide. This guide will actually answer a couple of questions for you, such as what happens if you report on a quality code more often than necessary, how will CMS figure out your score, and what they'll do is they'll take either the most recent data or the most advantageous data for the measure supported. Also, it talks about physicians who all report individually within the same practice, and if they report quality data on shared patients, it will account for each physician in the practice. So there's some really good information in this guide, and it's important to take a look at that. The second document to find and read through is the 2018 Measure Specification Release Notes, also found in the CMS Resource Library. And this summarizes any measure specification changes. It looks like this, and I wanted you to notice that the document is specific to claims. There is one for the registry and one for web-based measures. There have been coding and or criteria changes to about 40 of the 2018 claims measures, including significant coding changes to breast cancer and tobacco use screening, and to the age-related macular degeneration exam measure. Therefore, if you reported claims for quality in 2017, they won't necessarily flow seamlessly into 2018. So please be sure to take a look at that. Okay, armed with all that information, now you're ready to locate the measure specification sheet for the quality measures that you've chosen. And the sheets are also located in the CMS Resource Library. So please read these sheets thoroughly for each measure and identify the patient criteria, the patient participation criteria. That's going to tell you the age range, any diagnoses that the patient might need to have to be included in the measure, and also what accompanying visit CPT procedure codes are necessary. And just a reminder, for claims-based reporting, you'll only include Medicare Part D patients, not HMO Advantage Plan patients, and only Medicare Part B, regardless of the age range. The measure specification will also give you the reporting frequency. And for example, some measures are reported once per performance period, and some are reported at each visit. They'll tell you the necessary medical record documentation in case Medicare does perform a quality audit for your practice. And finally, it will identify all the quality codes that are reportable on your claims. This is what the measure specification sheet looks like. This is the breast cancer screening measure, number 112. And you'll notice it has the submission type, claims only. This is a process measure. And the description tells you who to include in your reporting. So that would be women 50 to 74 years of age who've had a mammogram, and also the time frame for screening. And it also lets you know that there's no particular ICD-10 diagnosis code needed for this measure. This measure expects you to report this quality data with one of these CPT codes. And they are office visit, home visit codes, and the Medicare wellness visits. So you'll notice that non-covered preventive services such as 99397, are not included on this list because only covered services can be analyzed via claims data. So it's highly recommended for primary care offices to offer wellness visits. They're an excellent opportunity to address several quality measures and are also a good opportunity to update the patient's care plan and submit all applicable current diagnoses. And in this screenshot of the breast cancer screening specification, you see your first quality code, G9708, and that's an exclusion code. So that would be recorded when you had an encounter with women who had had a bilateral mastectomy or right and left unilateral mastectomy. And by reporting that code, that would exclude them from the measure denominator. So Medicare won't really realize that this measure is not applicable to them unless you report this exclusion code for your patient. This slide shows you two more quality codes for the measure, the performance met, G9899, and the performance not met. And just so you know, this is not the full set of codes for breast cancer screening, but it does give you an idea of what to look for and what to pull out of the measure specifications. So now let's talk about coding workflow. If you code manually with an Encounter form, then you can create a quality coding sheet or add the codes and descriptors to your existing Encounter form or Superbill. This is a coding Encounter form that we use with our practices that we support. And you'll notice that all applicable quality codes in each measure are available for provider selection. It's important to offer all of the codes to the providers rather than just ones that meet the measure. So on this Encounter form, we have the exclusion codes, some due to hospice. And again, exclusion codes are important because they'll remove that particular patient from the denominator for that encounter, thus preventing a negative impact to your performance score when that measure is not applicable to them. The Encounter form includes the measure when the measure is met, and then a reporting code for when the measure has not been met. And hopefully the unmet measure reporting will be a rare occurrence due to your provider and staff training. This is an example of how quality codes are reported on a CMS 1500 claim form. We know that some critical access hospitals may use a different claim type. However, the quality code is reported in the same spot as other CPT and HCPCS codes. Some quality codes on the measure specification sheets will be followed by a with IP or with HP, and those are modifiers. So they're just reported in the modifier space on the claim form. If your EHR doesn't actually report for you, but you enter your coding into it for billing, then you want to work with your vendor to activate and or map quality codes into your charge master, into your EHR, and review and deactivate any quality codes that you no longer wish to report to Medicare or to other payers. Verify that the quality codes you need are set up in your billing system. CMS strongly suggests a 1-cent fee amount to ensure that the quality codes actually populate the claim. Some providers told us that they didn't need to add any fee in order for their quality codes to drop to the claim, and another provider said that he needed to add $1. So just please see what works to your billing system. Run some test claims to make sure the codes are dropping. And then check your explanation of Medicare benefits, your EOMB, remittance advice, for processed quality codes. You should see the denial N620. This procedure code is for quality reporting purposes only. And just be aware that according to CMS, the remark code N620 only indicates that the quality code passed into the NCH database. It doesn't indicate whether the MIPS quality code is accurate for that claim or for the measure that the provider is attempting to report. So in other words, CMS doesn't monitor the accuracy of the codes through the claims processing. Staff education is very important to your success. Make sure that all staff are aware of what measures the practice is reporting so they can assist in capturing data and documenting in the medical record. For example, if depression screening is a measure that you choose, your medical assistant may be the one to fill out the PHQ-9 with the patient and enter the data into the medical record. Ancillary staff may assist with medication reconciliation, fall risk assessments, or advanced care planning, just to name a few. So it's important to enlist all staff onto your quality team. And before we get to questions, I'm just going to flip to this resources slide because this is the all-important link to the 2018 CMS Resource Library. And there's the Quality Payment program website that has just a ton of information for you on that. And I also wanted to point out the Nationwide Small Practice MIPS support site. If you go onto this site, you can scroll down and there's a map of the United States, and you can click on the state you live in to see how you can contact the organization that can offer you some boots on the ground specified support around MIPS reporting. And then there's also our New England QPT Ask a Question link there. So thank you very much for listening, and I'm going to hand this back to Morgan, and we'll see if you have any questions for us.
Okay, thank you, everyone. At this time, we'll take some questions. If you would like to ask a question, please press #6 to ask the question over the phone, or you can pose your question in the chat box. We will take as many questions as we can. However, please be assured if your question is not addressed during this webinar, we will make sure someone gets back to you to address your question. At this time, please begin your question. Rachel, would you like to read Brooke's question?
Oh, what's your question?
Yeah. Okay.
Hi, sorry, this is Rachel. I was trying to get off of mute. Sorry, this is Morgan. I saw that you answered a question for Brooke, but I didn't see the actual question from Brooke, so I didn't know if you could kind of go over that for everyone. Thank you. Okay. Yeah, no problem. So Brooke's question, she said, I was advised by our EHR provider that it is best to submit as many measures as possible, and CMS will select the best score. And that was a question verifying that. And do you suggest doing this? So my response was basically yes. Well, yes, CMS will score all of the measures that you submit, so you can submit as many measures as you like. However, there are some considerations you want to think about before submitting, every single measure that you possibly can. Again, it could be a lot of work for a provider to be coding a lot of these different measures. Also, I believe, and again, I'm not the coding specialist, but I believe with this, some billing, it can be affected by the amount of code you submit or how much you're paying a billing vendor. Also, the data that you submit to MIPS is going to be used on Physician Compare. And so although I don't have a whole lot of information about what that's going to look like, CMS will be releasing more information, but you might want to think about that before submitting measures that you might be lower performing in, or you might not have sufficient data because that may go up on Physician Compare. So that's just another consideration to think about.
Okay, a question from Michael is the 2018 benchmarks by submission method document available yet, i.e. tapped out measures, etc.?
Yes, that is available. It's on the CMS Resource Library, and if you scroll down when you get to that site, there are 4 areas that you can pop into, and the 2018 data is where you would go. And then on one of the first slides I had, you would open the quality measure supporting documents download, and then open the claims registry file. It's the same location the 2018 measures list is in, and so the benchmark information is also in there. So yes, it is available for you.
Okay, the next question is from Susan. We see many SNS patients. Where can I find quality measures reportable for that setting specifically?
Right. That's it's going to take a little bit of digging to find that, but what you would do initially is go to the measures list and choose measures for things that are possible for you to do, that your providers do. And then what you're going to need to do then is go to the measure specification sheets for those measures, and they'll tell you whether or not the SNF location, the skilled nursing facility location, is reportable for that measure. A lot of them have been excluded from that setting, but and then it will also have within the measure where we talked about the CPT codes that accompany the quality measure, the SNF visit codes will be included in some of the measures. So you'll be able to root them out by using that method. And if you still have trouble with that, reach out to either us or your supporting organization so we can just give you a little more assistance with that.
Okay, there were a couple of questions about the slides. They were posted at the beginning of the chat and in the middle, and we will post the link again at the end of the chat. From Sharif, we have our EMR software is different and separated from our billing software. Would this be a problem reporting?
I guess it depends on the exact situation. It depends on whether or not your EHR will actually capture quality data for you. If your EHR is just a medical record and you're using counter forms, then you could still report via claims and just manually enter your quality codes along with your visit codes. But I guess I would need a little more information, want to process that with you a little bit in order to answer that more fully.
And actually, Susan, if you want to advance to the next slide, I think it shows your contact information. So if people, that way people want to get in touch with you for more clarification on their questions.
Excellent. Thank you, Morgan.
Okay, from Mona Ray, if N620 is reflected on our EOBs, then our reporting has been done, or is there something else we need to do?
If the N620 is reported on your EOB, then you have completed reporting successfully. The only thing to be aware of is, again, as I mentioned, CMS will not let you know if that quality code is no longer applicable to the measure. Some of the code, as I said, there were many code changes for 2018, so some of the codes reported last year for a measure are no longer applicable. So that won't be reflected on the EOB. So just make sure that the quality measures you are reporting are the right ones, and then if they are, then when you get that reported back to you on the EOB with the N620, then you've successfully completed claims-based reporting.
Okay, from Virginia, I report on claims, and when I sent 405F, pharmacologic therapy prescribed, it asked for a modifier on the instructions. It said to use a modifier if medication is not. I guess is not required listed.
Okay, what I would like to do on that one is to research that a little bit. So if you could reach out to us with that question, that would be great.
Okay, from that, we have, is there a way for us to check throughout the year how our reporting is going?
That's a good question. We hope so. We hope that CMS is going to load that feedback for you on the QPP submission website. So for those of you that have obtained an EIDM account, an enterprise information data management account, and have logged into the QPP website, you may be able to see some feedback there from CMS. That is what we're hoping will happen.
Okay, also from that, I know we don't report on HMO plans, but what about an AARP, Medicare Complete PPO plan?
The only, that I believe is an HMO plan, or anyway, anything that isn't a regular Medicare Part B, you would not report on. So it needs to be the regular Medicare Part B sent to the Medicare Part B claims center, and I believe the AARP Medicare Complete is a different plan administered through AARP. So you can verify that, but I wouldn't think that would be one you'd report on.
That's all the questions we currently have in chat. However, remember, if you want to ask a question, please press #6, and you can ask your question over the phone.
Hello?
Okay. Go ahead with your question.
Okay. We submitted 6 measures for 90 days in 2017. So I know, my understanding is in 2018 we're supposed to be submitting throughout the year. Say one of our measures is we're following a patient with hypertension. Do we have to submit information on the claim? Say this patient has been 3 or 4 times in 2018. Do we submit it every time, for instance, this person's blood pressure, or not?
The answer to that will be on your measure specification sheet. It will tell you how many times during the measure period to report that. I don't have that measure right in front of me. As I recall, I think it's reportable each time at each patient encounter, but I think the best thing to do is to take a look at the measure specification, and that will give you your answer.
Okay, thanks.
Yep, you're welcome.
Okay, from Suzanne we have, our EHR company states they are only allowed to provide certification to our attestation if we have all of their products in use, such as ePrescribe. We should be waived from ePrescribe as we do less than 100 prescriptions per year. Would their certification with a clause stating we do not have ePrescribe be acceptable to Medicare if an audit ensures?
So the best thing to do would be to go online and take a look at it's the ONC website, and I'll try to find the link and put that in chat. But you can search to see your EHR vendor and the version type that you're using, and it will state right on that website whether the version type that you're using is certified to 2014 or 2015. Based off of that information and the fact that you do not have more than 100 prescriptions per year, you should be excluded from the e-prescribing piece. But I will try to find that link real quick and put it into the chat.
Okay, and from Susan, she wants to know, does the 60% of reporting mean that you need to do 6 measures on each patient, or can you do one on 60% of all patients?
I think you're referring to the 60% data completeness for the quality category this year, and what that means is you would want to report quality data on at least 60% of the applicable patients. So in other words, if 100 patients all came in and the quality measures you'd chosen were applicable to them, you would want to report on at least 60 of them in order to be successful in that category in order to get the full score for that category. So in other words, what your strategy is to try to report on 100% of your patients, and then for the ones that it gives you a little wiggle room for some error and still be able to accomplish 60% data completeness within that category.
And from Virginia, is the reporting period 1 year?
Yes, it is. For quality measures, it is 1 year. And I know this is January 31st when we're talking about that, but just be reminded that some of the quality measures are reported only once per performance measure. So I think it's still a good idea to just go ahead and launch into your claims-based reporting. And you may be successful in many of the measures, even though you're getting a little bit of a late start.
From Jane, I've received 2 referrals in the last week stating that their claims with the QDCs and associated penny charge are being denied. Any insight on this?
Actually, I'm not sure I think if you could reach out to me, that would be best, because I have a couple questions about if they're coming back as denied on the EOMB, on the Medicare explanation of benefits, then that's normal that they be denied for payment, but you would want to see that N620 code. So anyway, I guess I need a little more clarity on the question. If you could reach out to me, that would be great.
And from Beth Weehaus, is it okay that our 6 measures are measure type process?
It is important to have an outcome measure, but if an outcome measure is not available to you, you could pick a couple of high priority measures. It depends on your specialty to see if an outcome measure might be available to you. So again, I think if we could have a conversation, that would be excellent. If you could reach out to us, that would be great.
And you can unmute yourself if you want to clarify that now by pressing #6. If there's no further questions, Susan, can you advance to the next slide, please?
Yes, certainly.
Okay. The New England QIO has a patient family advisory council that helps inform our work. For more information on that, on what they do, who they are, and the work they have contributed to, please check at the website shown on your screen.
Next slide.
Next slide, please. Okay. Thank you all for a great discussion. I have a few final announcements before we end today's call. As a reminder, we are now on social media. Visit us on Facebook, LinkedIn, and YouTube. When we close out this webinar, the evaluation will automatically pop up on your computer. If you could please fill that out, we would greatly appreciate it. If you don't have time to fill out the evaluation right now, or you're currently sharing a computer with someone else, you'll receive an email tomorrow with the link to the evaluation as well as a link to the event page of our website. The PowerPoint presentation was in your Day of Details email and will be posted on the website. Within the next few business days, the recording and transcript of the webinar will also be added. Thanks again for attending, and have a great day.
The leader has disconnected. The conference will be terminated in 5 minutes.